Good morning. It's wonderful to see so many of you here, and nursing and all the different health professionals and leadership. Well, those in leadership, I hope you'll be running for my seat pretty soon. I bring you greetings on behalf of the Maryland General Assembly. Thank you so very much, Dr. Belcher. I'm sorry you have to leave, but I understand. Bring you greetings again, as I said, on behalf of the Maryland General Assembly, and it's indeed a pleasure to be with you this morning. So my topic, of course, as you know, is Room to Grow, the journey for cultural and linguistic competency. I always, of all the forms of inequality, the injustice in healthcare is the most shocking and most inhumane. Many of you here have heard it over and over, but I always want to say it again, because Martin Luther King always had a vision, and his vision was just that we need to do better in what we do as we address healthcare and health disparities. So let's go over quickly your learning objectives, and they are, of course, at the end of the presentation, you'll be able to list the major historical events, report between 1895 and 2012, probably should have been 2015 anyhow, that moved the nation to address cultural and linguistic competency, a tool to reduce minority health disparities. I'm going to go over this with you because I want to make sure at the end you have achieved all of this. List major development in Maryland from 1987 to 2004 that focused the state on the needs to increase cultural and linguistic competency in healthcare delivery. Discuss why linguistic competency is becoming an important measure of effective healthcare organization, and to discuss how healthcare organization can improve cultural and linguistic competency to build a world-class delivery system. And so Maryland and the nation continue to face a healthcare crisis within racial and ethnic immigrant communities. Cultural and linguistic competency are at the heart of this crisis. And so as you see the graphics, it speaks to respect, and I'm sure you all know that if you don't give the kind of respect that is needed, you begin to lose it right off, okay? Communicate, because if you don't respect that patient, and that patient feels comfortable that you're respecting them, immediately you're not going to be able to properly communicate with them. And make sure there's understanding. You understand them, they understand you. Because so many times we rush through and we don't give them the understanding of what we're about to accomplish. And of course, engage. You have to engage them to be able to get the outcome that you need. And so let me start with a historical perspective. And this is one of my favorite parts, the nation's journey of the cultural and linguistic competency. And it goes all the way back to 18, and probably even before, but it was documented in 1895 that Booker T. Washington and W.E.B. Du Bois at the Atlantic Exposition spoke about the deficiencies in Negro health immediately post-slavery. In 2003, W.E.B. Du Bois, the Philadelphia Negro, door-to-door social study. That was one of my first reading when I came to this country and began to get the understanding of what, at that time, they didn't speak about the deficiency, they talked about bridging the gap and how do we bridge the gap. And so in 1968, you had the Kerner Commission report, Black health inequities remain severe. 1968, many of you weren't even born, okay? In 1985, HHS Secretary Heckler, Margaret Heckler, Task Force report on Black and minority health, continuing disparities. Margaret Heckler was a member of Congress before she became Secretary of Human Services. She was a Republican woman who saw the vision. So it's not just one-sided. It's really a bipartisan approach in trying to address racial and ethnic disparities. Margaret Heckler commissioned this, and of course, with Congress. And a man by the name of Dr. Malone was the chief investigator. And it said that 60,000 of us, African Americans, die needlessly due to lack of access and quality of care. 60,000. That was back then. You can still read, I'm sure you can still find that documentation in the library, in the book. But I was privileged to meet Dr. Heckler. Secretary Heckler. I think the last time I met her, she was in her late 80s, going on to 90s, and she was just as spry as she could be. Dr. Malone, I was privileged because I'm the founder of the co-founder of the Black Mental Health Alliance. And at that time, I had the Maryland Black Congress on Health Law and Economics, trying to see what we could do to address some of this issue. And he came to Baltimore to be my keynote speaker. So, and I can probably just go back a little bit and tell you, although it's not on the screen, so you'll understand when my passion came about to start dealing with this issue. It was back in 1979, again. I attended, as a member of the Black Nurses Association, I attended a meeting in Washington, D.C. that was put on by the National Medical Association. And then I began to hear him talking about the bridging the gap, and start giving statistics and numbers in terms of morbidity and mortality rate in Black and minority communities. And so I began to listen and pay attention at that time. So that was my first eye-opener. And then I got very much involved with the Congressional Black Caucus Health Brain Trust and started going to all your meetings on the Hill. And it was in that kind of context to which my eyes were opened to some of the issues that we needed to champion. And so in 1999, the IOM report on equal burden of cancer inequities of service delivery and lack of access and quality. In 2002, wow, fast forward. There's a lot of things happening in between, but I'm just giving you the big ones. 2002, the IOM report on equal treatment was confronting unequal treatment, racial and ethnic disparities in healthcare. It was, again, another catalyst to open your eyes and say, hey, you know, here the IOM is coming out with a report, finally documenting all the things that we've known for years that nothing had been done about. And so I was fortunate to meet Dr. Smedley, Brian Smedley, who heads up that particular, that he was the chief investigator in the Institute of Medicine. And quite recently, I was privileged to hear him speak at the Shirley Nathan-Pulliam Health Equity Lecture Series. And so, and I think Dr. Belcher was there too. He was terrific, wasn't he, Dr. Belcher? In 2010, the Affordable Care Act came about, promoting cultural and linguistic competency in healthcare. And I was privileged to work with Senator Ben Cardin to elevate certain federal departments, CDC, SAMHSA, the NIH, CMS, HRSA, FDA, HHS, the Office of Minority Health, and AHRQ, Agency for Health Research and Quality. That really, and how that came about is that we know the bill was moving and it was getting thicker and thicker and the pages were getting big. And we wanted to say, we can't let this opportunity go. There was a woman by the name of Fredette West who, even when Fredette was ill, she continued to walk to the Hill and she wasn't getting anywhere. Then at the time, Senator Kennedy was very ill because we were trying to get him to put it in. And we couldn't move it from there Then we went to Secretary Reed's office and a couple of the others. I mean, not secretary, I mean Senator Reed, and couldn't seem to budge his staff to put it in. I guess they were just thinking about how thick the bill was already. And so, fortunate for me, I've served for about 20 years on Senator Cardin's Health Committee in Baltimore. And so at the forum that he had in Towson, I asked him, does he understand, or does he and Senator Barbara McCoskey understand the morbidity and the mortality rate of African Americans, in the state of Maryland? And he said, yes, we do, let's talk. And so, of course, immediately after, I went to talk with him, and I said, we need to elevate the offices of minority health in these agencies. And I went to his aide, Priscilla, who we had tried to get through before and couldn't get through. But she did this time. And with that, the rest is history. They were able, we walked it back and forth, they cut it down until we finally got just enough pages to get it in. And so, as you know the history, there was so much stuff going on in Congress that I started lobbying Congress that if the bill came over, what needs to be done, not to take that part out. But however, it passed without a whole lot of problems, the history. So with that, that's how, and of course in 2012, you know all the history and the problems that followed the Affordable Care Act. So in 2012, the Supreme Court upheld most of ACA ruling on June 28th. And of course, I think this is a great statement. That great achievement is usually born of great sacrifice and is never the result of selfishness. That says much. And so now I'll tell you a little bit about the Maryland experience, the Maryland journey and cultural competency. When I went to the legislature I was elected in 1994, as you heard Dr. Belcher. In 1995, 1996, and 7, I began to put in bills and begin to try to educate my committee. I was then serving on the Environmental Matters Committee, which also dealt with all of the healthcare issues. And I was very much invisible. Nobody was listening. They weren't passing my bills, they weren't listening to the numbers. But I was persistent. I kept putting them in over and over and over. And finally, I start wearing them down. So I got a few bills passed through. And of course you had to be I got my first big break when I had my breast cancer legislation passed. And it was aimed at low-income women, inner-city low-income women, for diagnosis and treatment. But I couldn't put it that way. I had to word it differently. You got to word it because you have people coming from all over the state of Maryland that don't feel the same way you do. So I had to word it a little bit differently, and I was able to get that bill passed with great duress because I had it to 250% of federal poverty. And I worked with Bloomberg, the Greenboro Cancer Institute at the University of Maryland, and I was able to get $2.6 million put in the budget to provide diagnosis and treatment for low-income women. So that was my first little breakthrough. And then the next year, I was beginning to look at the cancer statistics in terms of oral cancer for black men and how high that was and how high we were in the nation. And so I put in a bill for $500,000, that's all I could get, to start the examination of African-American males. And so that was my first success, and I was excited about that. So fast forward to 2000 I'll come back and tell you about it. Let's go back a little bit to 1987. Now is the time. Action Agenda, the Governor's Commission on Black and Minority Health. Those findings, you can go to our library in Annapolis, the legislative library, and the book is on the shelf. Now is the time. All of that information that was in the ones previously was there, and even more disparity. Senator Larry Young at the time, was the leader in moving that particular the Governance Commission. And I was excited because I was serving on the mental health task force at the time. It was just after I ran for my first try. Those in leadership. In 1986 was my first try in running for the House of Delegates. And I lost that race, and so, but very, very narrow margin. And so in 1987, I was still very active, and this is how I got on that particular commission. However, nothing was done with the results. It just stayed on the shelf and gathered dust. So in 1996 was the Maryland 2000 reported mortality trend and disparities. In 2003, the Maryland Health Improvement Plan was a bill that I sponsored for statewide to look at the 24 local plans that were addressed. In 2003, HB 883, the Health Service Disparity Prevention Act. And by that time, they got a little tired of me. So they decided to give me my own committee, my own subcommittee. And so we became one of the first states in the nation that have a subcommittee addressing racial and ethnic disparities. And so in 2004, I sponsored House Bill 86, and I had it cross-filed in the Senate, establishing the Office of Minority Health and Health Disparities. And so I decided to do that because I wanted to make sure that it was in statute, that when the governors change and people change, that it would still be there. And so 2005, keeping the minority agenda on the table, building awareness in state legislature. In 1995 to 2000, it should be 2015, the Legislative Black Caucus of Maryland weekend, which we just had one a couple weeks ago, and I know Dr. Belcher did attend. The weekend, of course, has always addressed disparities and related policies. This past, many of you here, some Coppin State University was there, and it was on behavioral health. And just with the climate that we have in Maryland right now and then across the nation, it was very important for us to address every aspect of behavioral health. The term in office, and I think this number isn't really quite correct. I think my staff was doing their own research, but I have sponsored much more than 260 and have been, and got more than 76 that have signed into law. But I think that he was probably looking specifically on those that related to disparity. Okay, and so in 2000 to 2009, regional local media increased awareness, and I can move on. Back into 1985 to the present, partner with federal and congressional organization which address disparities. The National Partnership for Action to End Health Disparities. I was asked by the office, the Federal Office of Minority Health, to be a part of that. And the CBC, again, was the Congressional Black Caucus, Brain Trust, Regional Health Equity, the REC, what it means, Regional Health Equity, Region 3. I was an active member of that until I realized I couldn't do it all, which covered Maryland, Delaware, Virginia, Pennsylvania, West Virginia, and DC. So here we are. So you've gotten the national and you've gotten Maryland historical perspective. So what is cultural competency? And cultural competence can be defined in many different ways. Cultural competence is widely used terminology which is evolving to reflect a changing world. One definition that blends social variables to the demographic variable of race, ethnicity. We can go on. So cultural competence consists of overlapping of a set of attitudes, knowledge, skills, and awareness and attention to power differences which enable effective care to culturally diverse population. So we go on. Cultural competency operates in different yet intersecting levels of society. Social competency, societal competency, and it goes on to say, does society value the respect cultural differences? We have to ask ourselves that, because many times they do not. And how are different cultures depicted in the media? Organizational cultural competency, do the policy's vision, priorities, resources, allocation reflects cultural differences? And we go on to the program, cultural difference, cultural competency. But clinical cultural competency was a term that I coined way back in 2000. And I kept saying, I'm talking about clinical cultural competency. I'm not just talking about just regular cultural issues. I wanted to make sure as a nurse and as nurses and physicians and social workers and nutritionists and whoever we are, pharmacists and all of us who interface with patients, understand the importance of clinical cultural competency. And they are that the providers are trained for, are sensitive to, and respect cultural differences to achieve cost-effective outcomes. Our services, attitude, and behavior patient-centered. And our healthcare professionals knowledgeable about, listen carefully, to the medications and treatment modalities based on race and ethnicity. That is because, as many of you know, that African Americans and other minorities are not included in many of the clinical trials and studies that go on. And therefore, that physician or nurse practitioner or whoever is providing for that patient need to know their ethnicity, need to know what medication and what things work and what don't work, need to understand the different types of diseases and how to treat them and a lot of cultural barriers that come. I always tell when I was a young nurse on a unit at University of Maryland, there was a woman by the name of Hermenudo, was one of my professors. And Hermie used to emphasize about culture at that time. And it really didn't click. And she kept going on and on about culture. And then I decided to start paying attention to what she was telling me. And so when my patients came back from surgery, I began to look very carefully that if my patient was Asian, I'm going to put that patient close to the nurse's station, because get what? They're not going to complain. You have to go in and probably feel their pulse, see that they're sweaty and clammy, know that they're in pain, to begin to medicate them after surgery. Now, another person that I'm going to put close to the nurse's station is my Greek patient, or my patient, because he's going to yell for pain all the way down at the end, and wake up the whole, and if they're colorful Caribbean woman like me, you're going to hear, yeah, I'm in pain, you're going to hear me all the way at the end. So you got to get an understanding of what kind of cultures people come from and how they react to pain and so that was my first experience and my own demonstration of what happened to people with their different cultures. So cultural, and how should we think of the cultural competency? Cultural competence is not the same as cultural expertise. Most people are competent in their own culture. Few, if any person, are capable of becoming competent in another culture. Cultural competency is the ability to hold two-way communication and provide adequate, safe, and welcome services to a person of another culture. So, I'm not going to read all of this. I'm just going to let you browse through it. These domains, okay. And I go a little slower because I always get a little bit annoyed when I'm in an audience and they put up the slide and they move it so fast before I could get a chance to read it. Okay. And maybe this is why I've gone over some aspect of it. So what is linguistic competency? Linguistic competency is the capacity to communicate effectively and convey information in a manner easily understood by their diverse audiences. Now, when we hear of linguistic competency, people think, I got to go learn all these languages. No, you're not. There's about 87 or more different languages spoke. But you need to understand. You need to be able to listen carefully. One of my colleagues in the House and I, when I put forth the bill on cultural and linguistic competency, he decided to fight me that there was no that his constituents complain that he didn't understand their doctors, and they had doctors from Asia and different part in Indians and other, that they didn't understand the doctors. And so he wanted a bill that's going to say that they have to be able to speak English. I said, they're speaking English. They just have an accent. You cannot legislate accent. You cannot. So, I mean, he fought me. He put in all kind of amendments to kill my bill. And so we went back and forth on it. Of course, I won in the end, but that was, and it's a long story to tell you how I won in the end either. He and I really fought all the way. And he had my name on the radio because I was talking about linguistic competency, that I was a lover of illegal immigrants and aliens. And so that's how. And of course, instead of me being very nice and coy and behave myself, I decided to respond by saying if he was in his seat, 99% of the time he was missing. If he was in his seat, he would have known what it was all about. That didn't sit too well, so we had a little battle going on, and we both ended up before the ethics committee. But the ethics committee just said to me, don't respond to those things when they come, just ignore them. But he had to go before the ethics because he went beyond that. And so the day that he was called up before ethics, the bill came up on the floor for a vote. It got 99% of the folks on there voted for the bill. So this will tell you how things happen. So the U.S. population is growing due to immigration, increasing in diverse non-white population in the county and in the country, I should say. Considered immigration crisis in Europe and the potential impact it will have. And I'm sure I'm already start getting a whole lot of emails against Syrians coming to our shores. A whole lot of them start coming in. So census data tells us that in 2000, about 18% of the population spoke a language other than English at home. By 2020, this percentage is expected to increase significantly. Many of you, I go get my nails done, and then I would get annoyed. I was on television. I fought against English-only legislation. However, the day that I was getting my nails done, I was trying to explain to the woman that was doing the nail what I wanted done, and there was nothing happening. Okay, she wasn't understanding me, and I was getting a little bit totally annoyed that she was not understanding me. So with that, but then I discovered that one of the reasons why those people that speaks a different language tend to use it at home and the other, it really has to do with the brain. That's where they learn, and it's the easiest thing that comes out. And so it's not that many times that you're deliberately doing it. That's where they're comfortable, where they're zoning. But I got a little bit annoyed, and I said, what's wrong with this picture? I'm really, I'm fighting against this, and now I'm in here. But sometimes it has to take a different step for you to understand what is happening. So here we are. So there's a lot of stuff to read. Okay. So it tells you that linguistic competency, it has to do with effective communication. And that also goes for, you don't have to have another language. It could be me, because I'm Jamaican. I don't know if there's any Jamaicans in the room, but there's a couple back there. Okay, but I can speak a dialect. I can speak Jamaican talk that you don't know what the heck I'm talking about. I can hold a complete conversation. So if you don't understand my culture and understand a little bit about me, you will never be able to communicate with me in addressing many of my issues. For those with low literacy and non-health care language skills, to those with disabilities, to different age groups, children, teenagers, middle age, and seniors, to those with different levels of education that enables patients to adopt those health behaviors that lead to an achievable quality of life. So it is important that we understand many aspects of linguistic competency. And I could go on and give you examples, but I'd be here forever. So let me move forward. I think this picture says a lot. Linguistic competency includes the provision of interpreter service by properly trained individuals when needed in healthcare encounters. Linguistic competency is more than the interpretation of words, but includes the effective transmission of information. Do you see this guy sitting there talking to the statue? Now, is there anything happening? Is there any communication? Well, that is what really kind of happened when someone is talking to you and you have no understanding and you're not getting through, okay? And so it is so very important that we understand how people feel as healthcare. And keep in mind that somebody, your client, feels much more your patient, I should say, feel much more comfortable when they're being seen by somebody who looks like them and who sound like them. So if you don't look like them and sound like them, then you need to understand cultural and linguistic competency. And that is not just for, I used to tell when I speak on this issue, it's not just for Caucasian folks to understand. Everybody, black, white, whoever you are, you need to understand. Because you're a black physician and you've seen a black patient, there's a lot of folks that are black that's coming in. They're from Africa, they're from the Caribbean, they're from all over the world. You have to understand a little bit about the culture. I need to know when I'm a nurse on the floor that if my Jewish patient dies or my Muslim patient dies, they want to be buried within 24 hours. I need to know what needs to be done. I need to know who's going to be embalmed and who is not going to be embalmed. These are kind of things that you have to know and understand about people's culture. And so where do we as a state go from here? We talk about national standards for cultural and linguistic appropriate services. The class was developed by HHS and updated in 2013. I was privileged to be here in Baltimore at one of the, the focus groups to provide a framework for assuring services that advance health equity and quality while eliminating disparities. Cultural competency standards educate and train governance, leadership, workforce in cultural and linguistic competence, appropriate policies and practices on an ongoing basis. Linguistically competent standards offer language assistance to individuals who have limited English proficiency and other communication skill. And I want to share with you, when I was able to get one of the bills passed on cultural and linguistic competency, I had she's now a PhD and a professor at University of Maryland, Dr. Yolanda Oglebu, and she came to testify. She was my intern while she was working on her PhD, and I allowed her to testify on my bill. And what she actually did was talked about the number in the NICU of parents who come with so many varying languages, and they have to be able to communicate. So you may have some interpreter service, but the nurse need to understand how to communicate, and the doctor, to these parents about the condition of their newborn, whether the baby is going to die, what's happening to the baby, what's going on. And so by the time she finished talking about what's happening in the NICU, I got that bill passed too. So sometimes you gotta find how you can connect to get this move forward. Okay. So now we're here talking about room to grow. And I don't know who's keeping time on me. How am I doing with time? Because I was told I have 45 minutes to speak and to take questions. So you keep me posted so I don't, okay, because I can talk forever. Okay. All right, so when we talk about heading towards 2020, include the class standards in educational programs for health professionals. That has been there, but many people don't take the time to actually go online and actually do the course. Include class standards in the vision and priority goals of healthcare profession organization. Establish measurable goals and timelines for specific class standards. Collect performance and outcome data to track trends and to achieve and the achievement of class, to engage patient and family and communities in the efforts to achieve class standards, and to provide ongoing training to refresh plans and action to meet class standards, communicate and celebrate workers and programs that achieve class standards. Now, what did I do here? Okay, now it talks about all professionals. That's to you guys in the room that are becoming, that all professionals who are not trained in cultural and linguistic competence during your school or college times need to take courses in cultural and linguistic competency and health literacy prior to licensure and or relicensure. Now, when I put forth my first bill that speaks to this, way back in 2004, I had to take it out of the bill because the bill was not going to get passed. Okay, MedChi and the other groups lobbied to kill the bill. When I first put forth the bill on addressing that, I had Johns Hopkins as well as University of Maryland were not in support because they did not want me to mandate anything that has to do with their curriculum. So I kind of changed the bill to say recommend rather than. And so what happened since then, other states, such as New Jersey and others, took the idea of what I put forward and they got theirs passed. We still, fast forward to 2015, last session, I put forth the bill again. Again, I kind of changed it around to say at least 3 to 5% of the number of continuing education credits that is needed for, or CMEs that is needed for physician or nurse, and nurses we don't have a mandate, but to say that before licensure, begin to develop a system where you will be able to report back to your licensing board whether you've taken this course and you can show proof of it. Well, we fought back and forth, back and forth. So you know what we ended up with? I thought I had gotten a good piece of the bill moving forward with meetings after meetings just on this issue in 2015. And back and forth between the House and the Senate. And finally, what happened was the bill was watered down tremendously, but at least it came to say that the Office of Minority Health would work with all the different boards to put it up on their website, and they would put it in their newsletters and stuff to ask doctors to volunteer and ask nurses, ask the others to volunteer to take the courses in cultural linguistic competency. So what actually passed was a really watered down nothing, basically. Okay, so we're still fighting, and we have the whole group on cultural and linguistic competency and health literacy, and all of those from the University of Maryland and different people who have been studying came to testify. But it still didn't move because nobody wants anybody to mandate that they do it. Okay, so that problem still exists. So we have an annual Shirley Nathan-Pulliam Health Equity Lecture Series. It was created in 2011 and established by the Office of Minority Health and the University of Maryland School of Public Health Center for Health Equity. And so every year for the last 5 years, we have the Shirley Nathan-Pulliam Health Equity Lecture Series, which is done different places in our state. This past, it was at Martin's West. Yeah, that's where it was presented. And Dr. Smegley, as I said, was the lead sponsor. But Dr. Smegley is one who delivered it. He did an outstanding speech on the whole idea. Now, there's some other areas and room to grow before I do my total closing, is that I wanted to emphasize that there's several quality that there's a doctor by the Dr. Landry. He's an emergency room doctor who's been going around the state, going to the south and going different places. He's taken this on to increase the number of minority physicians and nurses. Most specifically, is emphasis on physician in the South, working to bring those numbers up. The other, the and one of the things in Room to Grow is that we can look at how we can reduce costs to bring quality minority students into health professionals and medicine. Providing grants and scholarships is needed, so you can reduce the burden of stress as it relates to loans and how they have to live their life so that they can be able to practice after they graduate. And of course, this would improve patient outcome. The last time I looked at the numbers, it was like Black nurses were about 9%, and dentists were about 4%, and I think doctors were about somewhere between 4 and 6%. It may have changed. I think it was Dr. Louis Solomon's report that talked about where they were and what needs to be done to improve. Because if we improve those, in terms, I think the statistics is like one in 15 in terms of the Latino population. It's in terms of 1 to 15 in terms of patient-doctor ratio. Okay, and it's the same. It's very, very high in the Asian population. When I looked at the study that was done by the Maryland Healthcare Commission, you had more Asian physicians in comparison to the population. So, and in African American communities, again, it is still very low. So we have a lot to do in trying to bring those numbers up. And so, okay, the journey began in 1800 with efforts to measure and document health disparities. Organization, educational institutions, elected officials, and others have continued to count poor health, the field that moved from counting isolated numbers to trending and tracking patterns. The language has evolved from minority health to health disparities and health equity. And let me say one thing here, is that health disparities exist. Health disparities exist. Health equity is where we hope to get to. And as I always said, in my lifetime, I was hoping that in my lifetime we will get there, but we're still moving tremendously slow. Okay, the circumstances and results remain the same, no matter what words we use. So many times we change those words around, and just as we think we get one thing, we change the word, change the meaning. Very confusing to many. Too many people suffer poor health and premature death in a nation with the wealth of the United States of America. The cost of health care stays high in spite of the efforts to lower the cost while increasing quality. And we have to remember that the physician-patient relationship is strengthened when the patients see themselves as similar to their physician and to their nurse and to their other health professionals. And their beliefs and have some of the same beliefs and values, and can communicate well with them in a patient-centered manner. So these are some of the things, because remember, trust is a big factor. Because if we don't trust and have the kind of trust in the professionals, we won't get where we need to go. And in the very shadows of Hopkins, as a nurse, because I still go in and see patients, okay? I am owner of 2 healthcare companies, and so I do see patients every now and then. If I get a call that the nurse didn't show up, I'm there. So I can give the medicines and I can do what need. And so occasionally I've gone out to patients' home, right in the shadows, right down in the Section 8 housing, close to Hopkins. And one woman that I was shocked when I went there, she had about 20 bottles of medicine, okay? There's only about 10 of those medicines were actually the same. I mean, what she should take. She had, she was double taking some of the medication because what happened is that when she goes to the pharmacy to refill, if the drug company, say for instance, if it's gabapentin or maybe one company gives a white pill, then I want to get a pink pill for the same dosage. So all she knows is that I take a pink pill for this and a white pill for that and this for that. And when I looked at what she was doing, she was overdosing herself. Many of the stuff was outdated too that was still there. And she was on dialysis. She was on food stamp. So by the time the third week of food stamp, she runs out. She has nothing. So therefore, how can she follow a low sodium diet and all the things that we want her to follow? And so I decided to go out and try to see if I could find some food. Well, don't go to the food pantries if you're looking for low sodium and low sugar, because the cheap food are high in sodium and high in sugar content. So I find myself going in my own pocket trying to find something. I think oatmeal was the only thing I could find in there that didn't have. So I just wanted to paint a picture so to let you know that this is not things what we're talking about. It's not stuff that used to happen. These are things that are still happening now. Okay, and it's even worse. When I go knock on the door and at a house, and the daughter comes to the door, is 79 years old, and her mother's upstairs, is almost 100. Okay, and the daughter can barely walk up the step because she's got high blood pressure, she's got diabetes, she's obese, and she has two little kids hanging on to her. This is the real story. Two little kids holding on to her. I want to know why those kids were not in school. I'd say the parents were incarcerated. And when I walked up to the room where the patient was in, she was a blind woman. And what was said at the time when I talked to her, she was very clear in her mind. And she said, "Don't my daughter know that I'm hungry?" I got called because the nurse's aide that I put in there to bathe her said she was still in the same diaper that she put on her in a pamper when she left on Friday. And so this is why I came. And I wanted to see for myself. The story goes on much worse than that. But what I finally had to do, I called the ambulance. And I really had to tell a little white lie because that she wasn't breathing well and stuff and get them there. Because what happened is that when the Adult Protective Service was sent out before, as long as the patient says, "I want to stay," then I'm okay. They leave them right there, regardless of what condition they're in. So that was what I had to do. And the daughter just said plainly, my mother said she never wanted to ever be in a nursing home. But then as she got sicker and she got older, she could not manage, and she didn't know how to ask for the help that she needed. That's real, okay? So we have many problems. As you go out in the community and begin to do public health nursing, you will find some of those issues still exist. And so I think I am just about finished here. Okay. And I'm coming to the end. Okay. For 2020, we must build on the past efforts and successes while learning from challenges and barriers. We must blend all of the words and concepts from the past to develop a fresh and innovative strategy to improve the health of the most sick among us, and at the same time, safeguard the health of the well. We must keep a clear focus on the goals of securing the best and most achievable health of the masses of our population. This is what a nation that is a leader among nations would do. Maryland can show the way. And so, although we have made great gains, tremendous challenges remain in educating health professional and legislative bodies. Legislative bodies, and I can say it to all of you, need to be educated. You have that responsibility to educate them. The decisions that are made that impact healthcare is made by people that many times don't have a clue because they're not health professionals. On the health committee that I serve in the Senate, I am the only health professional. Okay, in the House, there were probably three of us. Well, now in this last election, there were three physicians now in the House. There are two nurses in the Senate. But we're not on the same committees, we're on various committees. It's important that you know who your elected officials are. You know who your senators are, who your delegates, who your local council is, because that's the only way you can make changes, by educating them. And so, from 1895 through 2015, over 120 years, we have not come that far. In my lifetime and yours, I hope that we can make a significant difference in the lives of those we touch in health, as health professionals. So as Martin Luther King says, I close, our lives begin and end the day we become silent about things that matter. We cannot be silent. We've got to speak out. We've got to say what is not right to make sure that each of us, and let me tell you, in this healthcare delivery climate, you've got to be an advocate. You've got to advocate for your clients, and you have to remain non-judgmental. Not because unless you walk in their shoes, you'll never have a clue at what they've gone through. I thank you. Do you have time for any questions? Okay.
So we'll just take a few minutes. Are there any questions?
I mean, I told you everything that you don't have any question. Okay. Well, I probably will, since you don't have any questions. Oh, there's a question over there. Yeah. You got to speak up just so I can hear.
My question is there grants that are available to do some research on the health of African immigrants?
You know, there was, I remembered, I don't know right at this time, I know that about a couple years ago, there, a physician out of Montgomery County was able to get a grant. We were looking then on hepatitis, more specifically on immigrants with hepatitis C, because I've been putting in bills on this issue, and it's not passing, okay, with a growing number of people with hepatitis C. So, and we had a lot of people coming in from Cameroon and from other immigrant countries that had high percentage of hepatitis B and hepatitis C. And so he did have a grant, but of course, the problem is that when the grants finish, there's no money to keep those programs going for the immigrant public. So that's maybe something we have to pay more attention. You keep in mind that it's kind of, you're not going to get any out of Maryland. You got to look nationally and then federally to see where grants are, because you have so many people that are still very dead set against immigrants getting any help. Okay. Did you hear me? Anybody else have a question?
Any other questions?
Okay, just wanted to say that if any of the nursing students, well, any of the students, when session starts back in Annapolis, I'm always available if you want to. If you want to shadow me, you can call my office in Annapolis, 410-841-3612. And they usually talk to my chief of staff, Josh, or my legislative aide, Elaine. And they will set up, if you want to shadow me for morning, you got to be ready for early in the morning. You got to be ready to run, okay? I hope that I'll be able to run when I go back, because I had total knee replacement in between. So I'm kind of still struggling to get around. However, that's an opportunity for you to come and actually see how, and what I will say is there's a young lady with a question there. There's one young lady with a question right there. But I just wanted to say it is really, we as health professionals really should have much more power, and especially those in the nursing and pharmacy, nutrition, and other health allieds, because we are some of the largest health professionals in the world and in the United States. And yet still we don't have the power, because we don't know who our elected officials are, and we don't stay involved with the process. Yes.
Good morning, Senator. Are you currently conducting any research? And if you are, would you allow students to participate?
Research? Mm-hmm. Now, I'm not doing research myself. Okay. No, because I'm a legislator. I'm down there. People come to me to find out how they can get the money so they can do, and most of the things, grants, and most of the things I put forth is probably capital expenditures, putting forth money so that people can build and do. We don't really work. There is a research arm, but they come for money, like for stem cell, and they come for us to fund their programs, okay? But we don't ourselves have money just for research. That's usually on the federal level. So, okay.
Write down her number for a shadow day.
Okay. With that, I thank you.
Thank you. Thank you, Senator.